And if you look at the landscape of cancers diagnosed throughout the United States, you'll see that many others lead the way in terms of the frequency, with breast, prostate, and lung cancer being the most common in men and women. Sarcoma is number 21 at the bottom here, with only 13,000 cases diagnosed last year, 5,000 deaths, which is a pretty high proportion. As you look, for example, at breast cancer, which is more like 15%, sarcoma is more like 30% overall mortality. So it's a challenging problem, which we'll hear about more in a second. But of all cancers diagnosed, almost 2 million in 2023, 13,500, about 0.7%, less than 1% are soft tissue sarcomas. And if you look at data from the SEER data, which is a national database over the last nearly 30 years, you'll see that the rate of new cases has climbed gradually with time, but started to drop in the mid-teens of this millennium, but pretty stable. And the death rate, we'd see it fall as therapy and detection improve, but the death rate for sarcomas has been pretty steady as well. Survival is really all about the stage of disease. So localized disease carries a much better survival rates, 5-year survival of 82%. You've got sarcomas with regional disease, which implies lymph node disease. The survival is lower, more like 60%. In stage 4 disease, 17%. The median age of diagnosis for sarcomas in this country is 62. And so it's sort of a bell-shaped curve, but you can see sarcomas diagnosed in pediatric patients, and they're continued to be diagnosed in octogenarians as well. And this looks very similar, but this is the percent of deaths, not diagnoses. And you'll see the median age is 5 years later for death from sarcomas, which makes sense, implying that patients who are diagnosed with sarcomas, live a few years at least before they die, 5 years on average. But this includes, other causes of mortality. So the death rate obviously increases with the age of the patient. And so even though this is a very rare type of malignancy, it's very, very extensive in terms of its presentation. And you think about lung cancer, well, lung cancer starts in the lung. You think about breast cancer starts in the breast. Hopefully those cancers are confined to those organs. But soft tissue sarcomas can be diagnosed virtually anywhere in the body, from head to toe. And the cells of origin are what defines the type of sarcoma that we treat, but the distribution and location is quite extensive. And we're not talking about metastatic tumors, we're talking about primary tumors, sarcomas, that start in one location and hopefully stay there, but as you'll hear, they can travel too. So staging is really what drives therapy and prognosis, and this is true for all types of cancers. And so the staging schemes for all cancers have quite complex, but sarcomas is not unique in that respect. The staging relates to the size of the sarcoma, the location in terms of how deep it is or superficial, the grade, which refers to the microscopic characterization of the cells, how bizarre or how similar they look to relative to normal tissue cells of origin. The presence of lymph nodes, which actually is a very rare circumstance, involvement of nodes for sarcomas, but is specific to some types. The presence of distant disease. So these are the 5 things that define stage, and stage varies from 1 to 2 to 3 to 4. And as mentioned, stage is how we define prognosis and how we decide how to treat patients with sarcomas. And then these are just some examples of the various cells of origin. Where do these things come from? Start. So schwannomas are soft tissue sarcomas of nerves. Nerve sheath tumors start in the nerve sheath. Bone sarcomas, such as osteosarcoma and Ewing's. Cartilage sarcomas, chondrosarcoma, synovial sarcoma. Angiosarcomas are sarcomas of blood vessels. Leiomyosarcomas are sarcomas of smooth muscle, like the intestinal muscle. Rhabdomyosarcomas are sarcomas of skeletal muscle, striated muscle. A very common type of sarcoma, liposarcoma, starts in the fat or adipose tissue. Fibrosarcomas, pleomorphic sarcomas, start in the connective tissue of virtually any structure, soft tissue structure. So who's at risk? I mean, it's a very small population. It's a very small percentage of cancers that are diagnosed and treated. But what drives most sarcomas? So genetic mutations may explain a clustering in a family of certain types of tumors that may include more than sarcomas, may include breast cancers. So a P53 mutation, an example of that kind of mutation. Patients who receive radiation treatment. Now, we're not talking about mammograms or chest CTs. We're talking about patients who are treated for other cancers. And so that level of exposure of radiation is substantially higher. And radiation is how we destroy cancer cells, but it's also how we can transform normal cells into malignant cells. So there's risks with everything that we do in cancer therapy and radiation therapy. One risk is secondary malignancies. So an example of that would be a radiation-induced angiosarcoma of the breast that we see about 0.2% of all patients who are treated with radiation for breast cancer. But most sarcomas don't have any associated risk factors or identifiable causes. They're very rare tumors, which leads to a whole nother set of questions. When we try and study these tumors, it's very difficult. 13,000 sarcomas a year. If you want to study a specific tumor type, they have to be similar. And if you compare sarcomas to the head and sarcomas to the toe, or these different cell types, they're so radically different that randomized clinical trials, which drive treatments for well-known cancers like colon, lung, and breast cancer, they're really next to impossible to perform. So a lot of data that we generate to drive treatments for sarcomas is based upon retrospective collections of patients who have like tumors. Is there a detection strategy for sarcomas? Well, yes, with something so unusual and unique, there really aren't any guidelines to screen for sarcomas. So it's mostly about seeing your doctor, paying attention to your body, and noticing things that evolve or are different. So most patients present with a lump or a mass. Depends where they are. If they're superficial, obviously you can find those more easily, and that leads to an earlier stage because they're found earlier. If they're deep within the abdominal cavity, you can grow sarcomas that are 20 pounds. And a patient who's obese, you may not recognize anything until more advanced symptoms present. And symptoms may or may not be present. If they're adjacent to structures of importance, there might be symptoms, but if not, they might just displace vital structures. But a thing to pay attention to for a lump or a mass is a pattern of growth. And that's a common theme for almost every sarcoma. So what do you do if you feel a lump or something that's suspected to be malignant sarcoma? You want to make sure you take steps. So don't watch it, take action. And as I've just described to you, early diagnosis is associated with early stage, and early stage carries a much better prognosis. And once a diagnosis is established, again, this is not a clinical diagnosis, this is not an X-ray diagnosis, this is a biopsy, a tissue diagnosis. We have to do a lot of things, and this tumor usually requires a team of cancer specialists that include many different disciplines, possibly surgery, most likely surgery, medical oncology, radiation oncology, pathology, physical therapy, occupational therapy, alternative therapy. Those are all things that might impact a patient's outcome and might be part of their treatment plan. So as I mentioned, sarcomas rarely spread to lymph nodes. Some do, but the biggest, most common thing that we would see is direct extension to other structures. And how extensively they infiltrate or invade other structures can dictate surgery or systemic therapy or radiation as a first step. But most sarcomas, if they're going to travel and become metastatic, travel through the bloodstream. And so the end organ most typically involved with blood-borne metastatic disease is going to be lung metastases. So a lot of patients, want to get scanned and see if it's traveled anywhere else. Are they necessary? They usually are, especially for more advanced stages of disease, but they're imperfect. They're not able to detect everything that's traveled beyond the local primary tumor. There are no approved blood. They're out there, but they don't have great sensitivity and specificity. For most sarcomas, we do obtain some type of cross-sectional imaging, which is a three-dimensional evaluation of the tumors to see how they relate to other structures, to determine size, and establish local invasion. Prevention, what do we do to prevent these tumors? And just like screening, there's not a good strategy because the epidemiology is not well defined. These are tumors that are not linked to diet or lifestyle. So we don't have any common themes to recommend in terms of prevention strategies. So the treatment for sarcoma, because it can be very challenging, might include all these different components. Surgery is almost always one of the things that we apply to treat sarcomas. Chemotherapy has its utility, but in general has not been very successful, like for other types of tumors to treat sarcomas. Radiation therapy more commonly does have some applications. And for challenging situations, the world of immunotherapy has changed a lot of different solid tumor treatments and outcomes, and that is true as well for some types of sarcomas. As you can guess, these different treatments work differently with different mechanisms, and so their outcomes can improve survival with an additive benefit. It's a matter of deciding which ones are most applicable according to the risks and benefits of the treatments and how aggressive the tumor is according to the stage. Immunotherapy would also include molecular testing to determine what kind of targets can be identified for treatment. So the first step is to stage the patient to understand the disease process as best we can before we start to treat. And as I mentioned, we might want to do some sort of cross-sectional imaging with CT or MRI. For more advanced disease, we're going to want to study the chance of distant disease with either a CT or a PET scan. And the next step is to decide what components of therapy should be used. Should it be surgery? Should it be radiation? Should it be chemotherapy? And so this really differs by the sarcoma subtype, by the size, by location, proximity to important structures, molecular targets. And then, of course, we need to decide which of these things comes first. Is it surgery? Is it drugs to shrink, to make the tumor smaller? So those are all decisions that need to be made prior to treating the patient. So categorically, early stage soft tissue sarcomas are most often treated with surgery up front. Surgery is the first step, and hopefully it's the last step according to what's found. So if something is presenting at a point where we can remove it with surgery and hope to achieve clear margins and eradicate everything that we can identify with pathology testing. Many times, most of the time, surgery is going to be the first step. And one benefit of surgery going first is that we actually obtain more granular data points about the tumor type. We know more about the size based upon microscopic dimensions, not imaging. And sometimes we know more about nodes and about margins. So we can then react to that knowledge and decide what else should the patient have besides an operation? Should they have radiation therapy? Should they have chemotherapy? Should they have both of those things in addition to surgery? But sarcomas with more advanced presentation, it's more common to think about preoperative treatment. And the reason that we think about preoperative treatment is to facilitate preservation of tissue and function. And so, as mentioned, the preoperative treatment might include radiation, it might include chemotherapy or targeted therapy. Something that City of Hope offers, which is unique to the Midwest and really offered only in cancer such as City of Hope, would include isolated limb infusion or perfusion. This is a treatment that's performed under anesthesia, where the limb is isolated from the rest of the body. It's essentially separated in terms of the perfusion with the blood flow, so we can deliver very high levels of chemotherapy into the affected limb, flush out the treatments, and restore perfusion to that treated limb. It's very effective, but it's become less applicable as targeted therapies have advanced. And if we do something like this up front, surgery then usually becomes the second or third step for these more advanced stages. And the surgery then leads to another set of variables that are defined with margins, with nodes, size. And so if there's a complete response to the treatment up front, which is always our goal with what we call neoadjuvant chemotherapy, that provides an excellent prognosis and tells us that we probably don't need to do anything else. But if something is done to shrink a tumor and then followed by an operation which shows us a residual high burden of disease, we're going to think about what else should we do? How else can we treat this tumor which has resisted the upfront systemic or local regional therapy? So for more advanced stages, neoadjuvant therapy prior to surgery promotes preservation of important things, musculoskeletal structures, and preserves nerves that might otherwise be sacrificed to remove a large aggressive tumor. It might preserve important blood vessels that provide blood flow to hands and feet. It preserves soft tissue. It limits the extent of the resection and provides a better cosmetic outcome. And most sarcomas treated 50 years ago of the extremities, as you might guess, were treated with amputation. So the sequence of treatment steps provides limb salvage. All these structures are preserved: muscles, bones, nerves, and blood vessels. So what are the technical advances in sarcoma surgery? Well, they really focus around preservation of tissue. And there are applications for minimally invasive approaches, but these don't relate to extremities. Laparoscopic or robotic surgery are excellent opportunities to minimize large incision length and disturbing structures around sarcomas, but they're only applicable for things that are in cavities such as the chest or the abdomen. The other significant advance in the last 10 years, I'd say, would be the improvements of the types of local regional anesthetics that we can provide patients before an operation is started. We can deliver drugs that provide excellent pain control that lasts several days and decrease the need for narcotics. As surgeons, we focus on surgery to treat sarcomas and cancers, but obviously there have been a lot of improvements in the medical therapy for these tumors. And so in some situations, surgery may not be performed at all. It might be local treatments that's affected with a targeted drug that can attack a sarcoma. It can be something that's targeting a unique feature of that tumor that can decrease toxicity and increase the chance for eradication. So it wouldn't surprise me if we have a much shorter list of sarcomas in the next 10 or 20 years as chemotherapy and immunotherapy techniques and drugs have advanced. So what do we do after we treat a patient that's had a soft tissue sarcoma diagnosis and treatment? There are essentially three different areas that we have to focus on for recurrence. Locally, where the tumor originated, regionally, in terms of lymph nodes that may drain, if applicable, and then distant recurrences. And the ones that we have a chance to cure are the ones that recur locally or regionally. And most recurrences happen in the first 18 months after diagnosis. And so we are going to focus periodically on history and physical examination every 3 to 6 months after their treatment's completed. In case we are treating or following something that is remote to physical examination, cross-sectional imaging of the primary site is going to be an important adjunct to screen for occurrences. And as I mentioned, most sarcomas are going to travel through the bloodstream, and the chest or the lungs are going to be the sites of destination for those situations. So a chest CT every 6 to 12 months is something that we do. And for isolated recurrences in the chest, sometimes those are operable, but are still considered stage 4. And the interval and duration of these surveillance approaches are defined by the stage, by the location, the tumor type, and there's a range of strategies, but most sarcoma survivors are going to be under surveillance for several years with their doctors. And the reason is, there are things that we can do. So if a patient has recurrence of their soft tissue sarcoma, we then want to restage the patient, assess the extent of their disease. And local or regional recurrences may be able to be salvaged or cured. It might include, again, approaches that shrink the tumor, and they might include approaches that are more aggressive in terms of their surgical therapy. So an amputation is an option that we sometimes need to consider. And then for those patients who present with recurrence that is distant or stage 4, we have to balance other things as well. We have to think about their quality of life in terms of their treatment choices. So that covers my slides. I'm happy to